Hello, and welcome to this specialized webinar titled Dimensions Embedding Quitlines into the Person-Centered Health Neighborhood. In this webinar, we're going to continue our discussion for the masterclass and focus on the importance of quitlines and how to embed them within the person-centered health neighborhood. We'll begin with a review of that concept before looking at quitlines in more detail and within the context of priority populations, and then we'll conclude with a look at practical potential next steps and how to set the stage for success. My name is Derek Noland, and I'm a community liaison at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus, where part of my role is to help diverse agencies to implement tobacco services and policies. I have a background in global public health and tobacco research, and I do have experience leading a research project evaluating the potential for quitlines to reach rural populations. And I'm joined today by my colleague, Jim Pavlik. So I'll now turn it over to Jim to introduce himself and get us started with today's presentation.
Hello, everyone, and thank you for joining us, and thank you to Derek for kicking us off. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program. And I've been with BHWP for just over 8 years. Most of my experience over that time has been in precisely the domain that forms the architecture of which this presentation is built. That is, making systemic changes that help care providers to make more robust care systems for their consumers, clients, or patients. In this particular case, we want to provide some high-level guidance for constructing effective and efficient quitline referrals. I think most of you watching this video are already familiar with what a quitline is, but if not, no worries. In just a few minutes, Derek is going to provide us a basic introduction to quitlines and discuss a bit about why we think they are such an important tool for addressing and closing tobacco-related health disparities. But before he does that, I want to introduce you all to what BHWP calls the Person-Centered Tobacco Cessation Health Neighborhood, or simply the Health Neighborhood, as I will call it for the remainder of this presentation. In order to understand what the health neighborhood is, we need to take a brief look at why we think this is such an important construct. And in short, there's a persistent paradox at the heart of American healthcare. One that many of you are probably really familiar with, and that is that America spends far more on medical care than any other developed country. However, for all of that spending, we really get mediocre health results. On the left side of the slide, you can see our medical spending in that dark red color compared to all the OECD countries in gray, with the average of those countries in that is that green bar. So the average spending on the right, you can see the results of that spending. America comes in close to or below average on several important health outcomes, including expected years of life at birth and lung-related hospital admissions. In orange, you can see that we're actually near the bottom in a lot of categories, including obesity, where we're dead last. And it's important to note that in many areas where we're already bad, we're actually getting worse over time, and that's sort of famously recently true with maternal deaths. So in the book, the American Healthcare Paradox, the authors make a strong case that one powerful explanation for this discrepancy between spending and outcomes is that medical spending is not the same as health spending. If we add all the other countries' contributions to both medical care and what we call social spending, then America is much closer to the average, which helps explain how we get average health outcomes. Another part of the explanation is not just that we aren't the topmost spender once social spending is included in the calculation, but that medical spending is inefficient in getting the health outcomes that we want. As we discussed in the masterclass, the care any individual receives in their doctor's office is responsible for about 11% of that individual's health outcomes. Combined, the physical environment and individual behaviors account for nearly half of health outcomes, about 45%. And these are areas that might be impacted if we decided to invest more in social spending. Now, this is the part where if you were attending a different webinar hosted by a different group, we may go into policy advocacy, legislative design, etc. And certainly that is one avenue for you to consider. But it is our belief that as individuals and as representatives of our respective organizations, there are some things we can do at our organizational policy level that can begin to grow a more responsive upstream approach to tobacco cessation. At the heart of this approach is developing a robust set of referral processes that are subject to routine inspection and improvement, which by itself is a decent summary of the health neighborhood. So as a reminder, when we say evidence-based best practices, what we mean is we want it to be evidence-based all the way through. And that begins with conceptualizing our tobacco cessation workflow around the 5 A's: ask, advise, assess, assist, and arrange. And using that 5 A's process to connect tobacco users to an evidence-based tobacco cessation intervention that is right for that client. Sorry, there's a buzz in my room. Where right is determined by matching the intensity of the dependence to a modality of care that matches that intensity with some combination of the duration and frequency of contact, the use of pharmacotherapy, and being a modality that fits the needs, desires, and expectations of the individual tobacco user. And of course, which is delivered in a way that can be heard and understood by the client, both in terms of its intellectual breadth and depth, but also in a way that engenders a trusting therapeutic relationship between the tobacco user and their care team, which is to say that it's culturally appropriate in all the ways that that implies. In the classic version of the 5 A's, a single care team, often a single care provider, performs all 5 A's, right? In fact, the 5 A's was developed by primary care physicians to be used by primary care physicians in the course of a single average clinical encounter. So in the original model, a PCP would be responsible for the entire thing and deliver it in about 15 minutes or less. Now, if you've been through a few of our webinars or other trainings, you may know that BHWP often recommends or defaults to a team-based approach, and ideally a multidisciplinary team. In any case, whether it's a single provider or a team-based approach is depicted by this slide, where the entire tobacco cessation suite of services is offered within a single provider's organization and ideally at the same address. But the reality is there are relatively few organizations that can provide all the evidence-based tobacco cessation services. And when there are such organizations like SUD treatment facilities and community mental health providers, both come to mind here, they're not often equipped to handle all those services for all individuals, right? Some facilities like that may have a focus on youth, young adult, or maybe criminal justice involved populations, and so they don't have any experts for senior citizens, right? Or an adult service provider may not have any youth experts, or individuals or individual agencies with a robust bench of Spanish-speaking providers may not have anybody available to speak to their Somali or their Southeast Asian diaspora communities, right? So, and in those cases, we expect that there will be referrals made to skilled providers that can provide that service to that individual. And of course, in the spirit of building a system of care, we expect that the organizations won't stop at the referral, but will instead engage in various follow-up activities, to make sure that the client is engaging productively in that care. And if not, try to discover why and correct that referral to something more appropriate. In fact, this concept of identifying what your organization can and can't do and who it can and can't do it for is the first step in building a health neighborhood. The second step is identifying who in your community, if anyone, can provide that service. And the third step is starting to build that relationship so you can confidently, knowledgeably, and enthusiastically make that referral. And then we have to consider that centralizing and prioritizing these referral systems is a critical fourth step. When we commit ourselves to the idea that there is basically no way that we can be all things for all people, then we understand that no matter what health outcome we're aiming at, we're going to need to think about tobacco cessation in discrete units, and those units need to be and have to be split up between various providers. And when we do that, we realize that our health neighborhood doesn't have to be made up solely of traditional healthcare providers like clinics, hospitals, and pharmacists, although obviously they will continue to play a role in the health neighborhood. But we can supplement their role with other government operations like jails and prisons and schools, libraries, other social service providers, religious organizations, even local businesses, restaurants, grocery stores, gas stations, etc. Once we have separated those 5 A's functions between those that require a clinical degree and those that don't, then we can help foster a community that knows how to screen for tobacco use and make appropriate recommendations for care. All that matters is that we know enough about our general service catchment area that we know where our clients are when they aren't with us and with whom they engage. And of those individuals that they're engaging with, which ones would be considered trustworthy enough to take health advice from. So before we go into a little bit of detail about how we can offer an effective and efficient referral system, I'm going to turn it back over to Derek to tell us what a Quitline is, just so we're all on the same page.
Thank you, Jim. With that important background in place covering the topics of the patient-centered health neighborhood, let's now turn our attention to Quitlines. Consider this section to be an overview of or an introduction to Quitlines, including a look at the evidence-based cessation assistance they offer, and again with special consideration to the priority populations we have focused on throughout this masterclass project. So what exactly constitutes a Quitline? Essentially, Quitlines are evidence-based tobacco cessation services that offer free or subsidized cessation coaching or counseling, and typically cessation medications as well, most commonly nicotine replacement therapy or NRT. Quitlines are available across the nation, with every state and the District of Columbia offering a Quitline with varying degrees of offerings, and a number of other countries run Quitlines too. As you can see, California was the first state to offer a Quitline in 1992, with every state having launched one by the end of 2006. Quitlines are primarily telephone-based cessation services, but in recent years, many Quitlines have expanded to also offer assistance via the internet, mobile apps, chat features, and text messaging, including automated messaging as well. They may also offer mail materials, referrals to additional services, and even training for healthcare providers about how to recommend and utilize the Quitline for their clients. And Quitlines have a variety of funding sources, including state and local funds, CDC grants, tobacco taxes, which when raised can often increase services and revenue, and funds stemming from the 1998 Master Settlement Agreement and also some public-private agreements. It's important to note that the efficacy of Quitlines for the general population is backed by a very large evidence base, and that they have a unique ability to reach and serve tobacco users, overcoming challenges such as geographic isolations, costs related to healthcare and transportation, language barriers, and many other potential barriers, just to name a few of these. Before moving on, I would encourage all of you to go visit the KICKIT California State Quitline website and become better familiar with some of the services that are offered there. This chart provides more detail about the number of Quitlines that offer the 7 FDA-approved pharmacotherapy medications. As you can see, at the time we produced this chart, most states were offering all 3 of the over-the-counter nicotine replacement therapy options, that being the patch, the gum, and the lozenge. A total of 47 states offered the patch, and 34 states offered all 3 of these over-the-counter options. On the other hand, the blue and orange bars represent prescription nicotine replacement therapy and non-nicotine prescription medication, respectively. And they show that all 4 of these options are offered by 5 states or fewer, primarily due to their higher costs. Even so, residents of most states have access to a wide selection of cessation medications to accompany their coaching sessions, which of course can be very beneficial. Okay, with that brief overview and background information behind us, let's now turn our attention to the priority populations that we focused on throughout the masterclass and consider how Quitlines can and have supported these individuals from these different groups of people. And once we've done that, we'll return to some thoughts about Quitlines in general. So let's begin by looking at low socioeconomic smokers, a priority population with a very high smoking prevalence rate, but also a group that attempts to quit smoking as much or perhaps even more often than the general population. However, that being said, individuals within this group are less likely to successfully quit and relapse to smoking more often than their counterparts. Another reason that I'm starting here is because individuals in low SES groups are more likely to have a behavioral health condition as well. Moreover, they may also be members of one of the other priority populations that we will discuss, or another priority population, and therefore may be subject to overlapping sources of stigma and stress and other vulnerabilities and disadvantages, including being more likely to be targets of tobacco industry marketing. And naturally, the impact of all these factors creates even greater health disparities within these groups. We also know that these individuals have less access to evidence-based cessation treatment, are less likely to use and adhere to available treatments, and as a result, have the aforementioned poorer cessation outcomes compared to the general population. Strategic approaches are therefore needed to overcome these barriers, and Quitlines can play a significant role in reducing the cost of services and increasing access. The existing evidence suggests that effective policies for reducing gaps between the low SES population and the general population are those that focus on recruiting low SES individuals into smoking cessation programs, those that support the use of nicotine replacement therapy, and also those that encourage adherence to pharmacological regimens and a greater number of behavioral counseling sessions. Okay, let's turn to Latinx quitline utilization now. And while we discussed the limitations of the Latinx definition in the masterclass and looked at how greatly tobacco use rates may vary among the many different subpopulations under this overarching designation, there is still value in considering this group as a whole. One of the chief benefits that Latinx individuals enjoy when calling a quitline is the common availability of Spanish language coaching and features. These are important services that can overcome the language barrier, although it remains true that there is variability within the Spanish language itself and the way that it is communicated. Even so, the presence of Spanish language services is a major benefit. However, even with this benefit, Latinx populations are among the priority populations that are actually least likely to access and call quitlines. Still, research has found that Spanish language media campaigns can increase Latinx quitline use. So quitlines do have the potential to alleviate this discrepancy. Some studies do bear this out and have seen positive results and impacts in this regard. A few other things worth considering are that Latinx persons tend to have lower intentions to call the quitline upon receiving a referral or becoming aware of the service through another means. This may partly be because of their tendency to perceive a lower need for assistance, and because this group is less likely to use nicotine replacement therapy, and with these points being particularly true with Latinx men. With this population, really for all of the priority populations that we'll discuss, positive quitline experiences may help to overcome this barrier and make people more likely to call the quitline. Okay, Asian Americans are another one of our priority populations of focus, and likewise, this group benefits from the ability to overcome the language barrier via the offering of the Asian Smokers Quitline and its predecessors. California actually began offering Asian language services as early as 1993. And then in 2012, federal investments via the CDC led to the creation of the National Asian Smokers Quitline, which then and today offers coaching services in the Chinese, Korean, and Vietnamese languages. Since its initiation, research has found that of the over 14,000 people who have utilized the service, over 90% of them have reported satisfaction with it over the first 7 years of its existence. And more to the point, it has been found that tobacco abstinence rates increase with quitline utilization, therefore furthering the benefits of the program. And all in all, quitlines have been shown to be effective in both reaching and serving Asian Americans, and they do represent an important cessation tool for this priority population to utilize and access. Okay, let's turn to the LGBTQ plus demographic group now and consider their quitline utilization as well. First, it is important to note that on average, the LGBTQ population initiates tobacco use earlier than other groups of quitline callers. In other words, they begin smoking at younger ages on average. And this trend continues later into life as members of this priority population continue to exhibit higher rates of tobacco use. There is not a great deal of existing research specifically on this topic, but some studies have found that LGBTQ quitline callers report higher rates of mental health issues than other demographic groups of callers, and therefore may benefit from supplemental services as well as those that the quitline offers. In addition, it has been found that fewer LGBTQ men are aware of the quitline when compared to heterosexual men, which indicates an opportunity for better campaigns and marketing from the quitline. When these studies are considered in whole, it does become clear that targeted outreach and tailored interventions have the potential to increase LGBT quitline utilization and ultimately reduce rates of tobacco use in this population. All right, let's now turn to African Americans and look at their quitline utilization. There is more research looking at this priority population than some of the other groups, but even so, consensus results are not always revealed. So in other words, there's quite a wide mix of evidence and findings across different studies. Generally speaking, however, African Americans experience quit rates similar to the white population. Some research findings have shown them to experience quit rates lower, and others have been higher, but overall, the rates are relatively similar. African Americans have been found to be more likely to be referred to the quitline by a healthcare provider than via self-initiated referral. And this finding suggests that healthcare providers can play a significant role in initiating African American quitline use and supporting their cessation efforts. To the extent that they're trained to do so, they can make a big impact here. Quitlines have also been found to be more effective in reaching African Americans than most other demographic groups and priority populations, with a study specific to California actually finding that they were significantly more likely to call than white people. Okay, with that overview of our priority populations in place, we'll now turn to look at the behavioral health population and people with mental health concerns over the next few slides. And to consider the role that behavioral health conditions play in quitline utilization and results, let's look at a 6-study quitline study from 2015, and one in which BHWP was heavily involved. And looking at callers from Idaho, Kentucky, Michigan, Montana, Ohio, and Pennsylvania, callers self-reported a history of a mental health condition at high levels, ranging from 62% in Montana all the way up to 89% in Idaho. And as an aside here, the national rate for self-reported mental health conditions among quitline callers appears to be closer to 50%, though there's a lot of variation in the studies here. We've seen some that fall below 50% and some that fall closer to 60%. So kind of a rule of thumb here. But to return to the study of focus, more importantly, the research found that while quit rates increased for callers without mental health issues, a substantial number of callers who reported a mental health issue or history also sustained quit attempts. In fact, upon reaching participants at 6 months after the quitline experience, 33% of those with a mental health issue had sustained their quit attempt, which did not compare too unfavorably to the 43% abstinence rate among those without a mental health concern. That final bullet point is worth considering too, that outcomes appear to be driven by how smokers feel their conditions may influence their quit attempts, which reveals the importance of not only screening for mental health concerns, but for evaluating individuals' expectations of success. Doing so and tailoring interventions accordingly could ensure the potential for better outcomes. Unfortunately, most quitlines do screen for mental health conditions and may be able to factor the status into their coaching sessions. So with that background, let's consider the role that cessation medications play for people with behavioral health conditions. One thing that stands out is that this population exhibits higher levels of nicotine dependence, with certain diagnoses within this category exhibiting particularly high rates of tobacco use and dependency. And while physicians and prescribers need to consider these conditions and if that individual uses any medications to treat them, in making recommendations about a specific absent a specific contraindication, there is no medical reason for these people not to use cessation medications. Adding to this, some recent trials of the use of varenicline or Chantix to treat schizophrenia and depression have found positive results, namely that the medication was effective and that there were no greater side effects. In fact, first-line treatments are recommended for all of these individuals with the aforementioned caveats applied. And treating people with cessation medications can make for a comfortable detox experience in settings where temporary abstinence from tobacco may be required for treatment. And so to summarize, Quitlines can utilize this resource with this population to achieve better outcomes in most cases, though individualized evaluations must always be made. Tailoring treatment to people with behavioral health conditions is another important aspect of Quitline programming, but the most important tailoring in this case is that which excites recruitment efforts and thereby generates increased interest and trust in the Quitline. Once people have enrolled in the Quitline program, then tailoring may be best applied based on that individual's specific demographic profile. Staff training alongside supervision and fidelity to programming can prepare coaches to work more effectively with mental health concerns and to achieve better outcomes, while screening is also an important part of recognizing their existence, as we have discussed. If staff are trained in specific techniques for these populations, such as cognitive behavioral therapy, mood management, motivation, and motivational enhancement techniques like motivational interviewing, they can achieve even better results. There's also expert consensus that these individuals often require far greater intensity of services and duration of treatment, and that patient-centered and strength-based approaches may be particularly valuable with this population. Again, coordination of care is important with this group, particularly where medication is concerned. Though again, not to confuse the point, they do benefit from cessation medications, as we have discussed. So let's look at some pilot outcomes. Pilot studies have been performed to look at tailoring programs for people with behavioral and mental health conditions. Several studies have found 7-day abstinence rates from tobacco for people with mental health conditions to be equivalent to general callers at the end of treatment and follow-up. In another case, from a sample of 844 callers to California's Smokers Helpline, those with depression attempted to quit smoking at the same rate as callers without depression, and approximately 1 in 5 of these people remained abstinent after 2 months. However, as it pertains to longer-term abstinence rates among callers, the findings really have been mixed, and tailored programming has not always been found to make a significant difference. However, other studies have indicated value in this approach. Nevertheless, some research has demonstrated successful tailoring, as I'm alluding to. In cases where mood management strategies have been implemented, participants have completed more coaching calls and received longer durations of nicotine replacement therapy. Greater participant engagement in text and email messaging has been found in these cases too. So while Quitlines have to weigh the feasibility of implementing these types of additional services and the costs associated with them and time and so forth, it is true that increasing engagement among those disparately affected by tobacco use is as important as increasing comparative abstinence rates. And in this respect, some programs focus on helping people with mental health conditions have demonstrated really encouraging levels of engagement. Okay, so here are a few conclusions that I came away with based on the study that I mentioned in my introduction. This was the study that evaluated Quitlines with respect to reaching rural populations and to driving their interest in calling the Quitline and maximizing their experience with the Quitline. However, a lot of those lessons are actually applicable to other priority populations too. And so I wanted to take some time to touch on those. And first and foremost, I do want to underline that important top point yet again. Quitlines work, we know this, and in fact, they remain a critical service in reaching select populations, and again, including the priority populations that we are discussing in this presentation. Because they work for a diversity of different peoples, the reality is that reach is the most overarching challenges that Quitlines face. Simply put, the more people Quitlines are able to reach, the fewer smokers there will be. And with that reality in mind, there are a few key opportunities that Quitlines may be able to exploit in order to improve their reach. For one, the more that Quitlines can integrate into existing structures and policies, the better. This amounts to capitalizing on ready-made interventions and access points. So in other words, aligning Quitlines with services that are already in place can take advantage of those services, enhance those services, and also lead more people to call the Quitline. Quitlines must also work to eliminate mistrust and misunderstanding, which is common across many of the priority populations that we discuss for a number of reasons, both historical and contemporary. Tailored marketing with clear expectations and explanations of the Quitlines service can help improve this aspect. And finally, every contact point needs to be maximized with good coaching and offerings, including technology when applicable. This can help to generate positive word of mouth and encourage more people to call. So the better prepared and equipped the Quitline coaches and Quitlines in general can be, the more that this aspect can be maximized. So before I wrap up this section in the next couple minutes, I want to summarize some of the tailoring considerations relevant to Quitline. Overcoming language barriers, including those related to literacy and understanding of the language in general, are an important first step, and one in which Quitlines have demonstrated success thus far. Prioritizing reach and the recruitment of callers is critical, as again, we do know Quitline services are effective with the populations they reach. Media and marketing that is tailored to priority populations can further this initiative. And importantly, Quitlines need to be easy and clear. People need to be able to understand what Quitlines are, what they offer, and as well as have easy means to access them, which may mean subsidized calling or phone minutes in many cases. As with their services, Quitlines should be transparent about any associated costs and should be clear and accurate to alleviate concerns stemming from medical distrust. It's paramount that Quitlines are very clear in all of their doings and their offerings, as any amount of mistrust can really undermine their services. And now let's consider barriers that are specific to Quitlines. So by their very nature, Quitlines rely on telephonic counseling, which takes access to a phone. It takes phone minutes, perhaps. You need to have cell phone coverage, access to the phone during work hours, and so forth. And not everyone has these resources available to them, or maybe they can't be easily reached via the phone during business hours. And so this barrier really is the fundamental one that faces Quitlines. Quitline marketing could be better tailored as well, as we have discussed, and aim to motivate and mobilize people to quit, and of course to call the Quitline. And as I mentioned, the power of positive word of mouth in the last slide, but unfortunately, bad news does tend to travel faster. So negative Quitline experiences have a tendency to spread more quickly. So they must be minimized, and Quitlines might also encourage people who have positive experiences to proactively spread the word and further counteract this phenomenon. Tied to the phone access concerns, Quitline calls take time to gather demographic information, and people may not expect this upon their first call. Moreover, they may be hesitant to provide such information to begin with. And finally, callers may have unrealistic expectations of staff skills and knowledge, which can set them up for disappointment. This is another concern Quitlines might proactively combat with clearer messaging about what their services constitute and what they do not. And so as a final thought in this section, I want to point out that denormalization strategies in which smokers are cast as outsiders or somehow flawed individuals, these strategies have the potential to compound stigmas against smokers and to further isolate them, making them even less likely to seek support and ultimately to quit successfully. So Quitlines and tobacco control more broadly need to be mindful of not portraying smokers in a negative light or as possessing pathogenic behavioral patterns outside of their own control. If these approaches are utilized, people may not reach out to the Quitline or other cessation services. So all in all, Quitlines and their marketing should focus on the power of positive messaging and strive to be as clear and consistent as possible. We know that Quitlines are effective and help people quit. So the more they can extend their reach, the more people they can successfully serve with this service. And with that, I'll now turn it back over to Jim for the remainder of this webinar.
Thank you, Derek. So we now know that what a Quitline is in brief, and we know that generally speaking, they work for all of our populations of concern, but we also know that they don't necessarily work equally well, or at least are not equally appealing to all individuals within these groups. So what are those things that we can do to make sure that our quitline process is effective and efficient for everybody? And very briefly, let me say what I mean by effective and efficient. These words are often used together, as I have been using them today. And in my experience, they are often heard as synonyms of each other. And while they do overlap a little bit, generally speaking, we are referring to slightly different things. By effective, what I mean is that the people to whom we make a referral actually pick up the phone when the Quitline calls them, and they enroll in services, and they engage productively with the Quitline. Now, that doesn't mean that I don't mean necessarily that the engagement with the Quitline will work, right? That's up to the relationship between the coach and the caller, but it's effective if it results in an actual contact with the Quitline. That's what we mean by that. And by efficient, I mean that the level of effort we put in and the number of enrollments that the program generates is optimally calibrated, right? That is, even with maximal absolute engagement, we will not ever get 100% of our referrals to answer the Quitline call. And with absolutely no effort at all, some people may self-enroll, right, without our help. So we need to make sure that we are engaging with individuals about the Quitline who are ready to enroll, but who would not enroll otherwise, right, without our engagement. And we need to engage with them in a way that motivates them to answer that phone. And we need to make sure that all of our processes are designed in a way to be sustainable, right? And that's another buzzy word. So by sustainable, I mean that the effort isn't so great or the results so bad that we can't justify the costs, no matter how small they may be. And by costs, of course, I'm talking about budgets, but I'm also referring to the psychological costs that are borne by our staff members when they're compelled to do tasks that do not generate good results for the people they care for. That is a form of moral injury, and that can lead first to unsatisfactory compliance with our plan, and then ultimately burnout. I said that effectiveness and efficiency overlap, and that's true. The more Quitline referrals that are acted on simply increases the ratio of acceptance to referral. And if every referral were accepted, that would be a ratio of 1. And if the effort to make referrals were also low, then that would be maximally effective and maximally efficient, which is to say that, simply put, a more effective referral system, all other things being equal, is also more efficient, right? So the point of efficiency is that it's the least amount of effort required to get the result that we want. All right, so with all that out of the way, let's start with some of the content here. So as a brief reminder, our full 5 A's can appropriately assess and connect individuals to any of the 5 evidence-based tobacco cessation interventions given a grade of A by the United States Preventive Services Task Force. Now, our 2 A's in an R model can also do this, but today we are talking about the referral to telephonic counseling. You'll see that in the orange there on the bottom, right? The AKA to a Quitline, AKA to Kick It California. Now, you may have already heard me say this in other LA County events, but in order to make sure your Quitline referrals are effective and efficient, you will need to engage in a tiny bit of assess and assist. And you will need to follow up with the client or with the Quitline to ensure that the effectiveness has taken place. Right? So in short, the 2 A's in an R is simply screening for tobacco use, advising the client to quit, and then referring them out, right? But the very first step in our aim for effectiveness is simply to make sure that our advice is both non-judgmental and also salient. That is to say, it resonates with the client. And I'll talk about this more in, I think, the next slide. But the short generic advice is for you to tie the advice to quit to whatever meaningful thing you already know about the client. That could be their current health or their mental health concerns, their love of their grandkids, their upcoming job or housing prospects, etc. And we want that Quitline referral to be as enthusiastic as you can muster. Both of these elements, or all 3 of them, depending on how you count, will increase the chances your client answers the phone when the Quitline calls. So, as I said a minute ago, that would be I'll try to be a little bit more precise on how to make the advice to quit more salient. And obviously, I I can't be even one iota comprehensive here. There are just multiple ways to make tobacco cessation salient for any one individual. But in general, and I get asked this a lot, even by professionals with pretty broad education in substance abuse treatment or even nicotine dependence treatment in particular, just how do I start the conversation? And the first bit of advice is really just start it any way you can. This question to me always seems to be asked like in the spirit of, I don't know if I know enough about tobacco cessation to navigate this conversation, or maybe in the spirit of, I don't want to lecture them. So, how do I get them to start talking, that kind of thing. So now a lot of this response is going to be highly dependent on the nature of their visit to you, right? And also the nature of your current relationship or the lack of a current relationship with them. So what I have to say here is just this is a kind of clunky all-purpose fit, right? It's clunky, but it works. It can work. Basically, just begin first by taking a deep breath and just reminding yourself that 75% of all tobacco users say they want to quit within the next year. And also remind yourself that 65% of tobacco users have tried to quit in the last 12 months. The chance that this client in front of you, with whom you want to start this conversation, is one of these 75 or 65% is not absolute, of course, right? But it's pretty high. And also know that the number of people who know that tobacco use is bad for them physically, and that it comes with a social price, that is basically 100%, right? Which is to say that a decent majority of the folks that you're talking to and with whom you want to have this conversation, right? And some portion of the remainder, they how to say it? Some portion of them, the vast majority of them, want to have this conversation with you, and the remainder understand why you're having this conversation with you, or with why you're having the conversation with them. They're not going to be offended that you're asking them about their tobacco use. So the next thing to do is to kind of locate this resonating prompt. In the example here, I wrote this for a pharmacist, right? The pharmacist has noticed that the client has been given medications to control their cholesterol. Well, while nearly everyone knows that smoking causes heart disease and lung cancer, they don't know that it affects their ratio of good to bad cholesterol. So this is a great potential opportunity to educate them, right, in a way that would resonate and link their health, right, and their health concerns with their smoking habit. The point here is, there's no reason to get too deep in the weeds. The point here is just to point out that the language that we're using is actually very simple, right? There's no judgment in here. It's really simply written. It's very matter of fact. Maybe even it reads a little cold, but that's exactly the point, right? That's what you can be doing, and you can write these down as scripts or prompts on your own based on the clients that you see and that you're thinking about having this conversation with. Also, do note that we do emphasize questions. We always want to be asking permission to share knowledge. If we don't do that, it can really come across as being a little paternalistic or lectury. So hopefully you all know about the stages of change. I have a link to a short webinar that I put together on the stages of change, and that link is actually in the policy webinar. So you'll also be able to find a link to that on the resources page as well. The reason I'm putting it here, the reason I'm talking about stages of change here, is to help you navigate the early stages of the tobacco cessation intervention. One of the things, we don't want to just come out and say like, hey, are you pre-contemplative? Right? They don't necessarily know what that means. The client doesn't know what these things are. So what are some of the things that we can do? And two of them are what I say operationalizing the stages of change, which is to say that you come up with a way where you can ask the question really directly, get a single response that would be consistent across anybody who asks the questions, right? That's what I mean by operationalize. So one way to think about it is just ask them on a scale of 0 to 10, how ready are you to quit? And then I have designed these rankings here. These are pretty standard. I'm not like taking credit for that. I just don't want to say that these are necessarily like the official ways, because what you may do is say to yourself, okay, here's the deal. Anybody who is in the preparation stage, then we're going to give them a quitline referral, right? And so then by my chart, you'd be asking anybody, or you'd be referring anybody who says they're a 4 or above, right? However, maybe your organization thinks that 4 is actually too low, and so you slightly change the number. So maybe contemplation is really 1 to 4, and therefore preparation would be 5 and above, something like that. And you can always tweak these things to match what your organization's goals are. The other one is to simply say, when are you interested in quitting? And you can actually do this in a written like like the intake form, right? And you say, do you smoke? Yes or no? And then if they say yes, then the next question is, when do you want to quit? And one of the options just could be never. So then you would find your pre-contemplators that way. Point being that their readiness to, or their stage of change is identified by how proximal their potential quit date is. So if they say they want to quit within the next 6 months, then we'd say that person is contemplating it. They're maybe not convinced, because there's a reason they're not saying this month or next week or whatever. So we say that person is in contemplation. And then if they say they are ready to do it within the next, say, 3 months, then we would say, okay, this person's really preparing. This would be a good opportunity to like educate them about the quit line, maybe not necessarily make that referral, because they're just preparing. So we'd say like, hey, what do you think about the quit line at this point? Kind of gauge their interest, et cetera, et cetera. And then once they're ready to move, they're going to be quitting within the next 30 days. We would say that person's taking action. And that's the point where we want to probably make the quit line referral. Okay. So I want to move into setting the stage for success. I always recommend doing some basic math about how time consuming your tobacco cessation effort is likely to be. When we recommend that all clients are included, there's an immediate fear that way too much time will be spent on trying to treat this dependence, right? Nicotine dependence. And it's just very hard to treat. And therefore, it ends with a lot of relapse. So which is to say that when I say like everybody should be engaged in this way, then organizations get nervous, like, oh my gosh, there's going to be so much time. So I like to go through some simple math, which often helps to make this process just more grounded in reality, and helps really start to help us allocate budgets and resources the right way. Now, I am going to talk about this first one, this possible criteria for referral. And I want to preface this part of the conversation by saying there are a lot of potential criteria for how you may limit who gets referrals, right? Here I say that level of interest in quitting, level of dependence, these sorts of things. And I'll talk about these in a little bit more detail. But the point being that if you go to the quit line and you ask them who they want you to refer, they're going to say, please refer everybody. If you go to the person who at your state public health department who manages that quit line contract, and you ask them who they want you to refer, they're going to say everyone. But the reality is that sometimes we can't do that. And in fact, doing so may in fact be harmful to the client directly, or to the relationship between you and the client. The most important thing in regard to supporting somebody through substance abuse recovery is the rapport between the mental health care provider, the substance abuse counselor, and the patient. And if somebody tells you, I don't want a quit line referral, and you give them one anyway, you are signaling that you know better than they do. You're signaling that you're not listening. You're really indicating that you're not necessarily a trustworthy partner, right? And so I say, don't do that. We defer to your judgment and their judgment on whether or not the quit line referral is right for them. So I think it's perfectly justifiable to say, just say, okay, well, they're not ready yet, right? They're not ready. A quit line referral is not appropriate for them based on their interest in quitting. I think this is justifiable. I would also say that it's potentially justifiable to limit that referral to people with more advanced, more intense dependence, right? So if somebody says, well, if they're only smoking socially, 2 or 3 cigarettes, on a Friday or Saturday. So a total of 12 cigarettes in a month, something like that. Like, and they're having trouble breaking their habit. It still might be the case that they don't really want professional help outside of whatever they would get from your office. They don't necessarily need nicotine replacement therapy. They're going to come across on the Fagerstrom test for nicotine dependence as a low dependence tobacco user. And so you may make the choice for your organization that you're only going to send moderate and up dependence scales up to the Quitline. That's maybe a little less justifiable than using interest in quitting, but I think it is ultimately justifiable. When I say medical or psychiatric complications, what I'm talking about here is the fact that, and this is also true of imminent harm, that with medical or psychiatric complications, what we're saying is that you may prioritize more complicated cases for the Quitline referral, right? Getting people off of nicotine may reduce the drugs they have to take. It may help them stabilize their mood after they're through that initial sort of withdrawal period. And that's a way of making a complicated case less complicated. And so you may prioritize those individuals for Quitline referral. So all other things being equal, maybe they come across as a low tobacco user, but so you wouldn't be making a Quitline referral, but they're coming across with these medical comorbidities or whatever. And so you're thinking to yourself, well, let's get them off the nicotine. And so you might prioritize them in that way. It's imminent harm to self or others would be the opposite, right? You might decide that we have to get this under wraps, and so we're not going to worry about with a Quitline referral. Similarly, if somebody's going through this, kind of skipping down to clinical priorities, but if somebody's going through an acute detoxification effort, your policy may be that they come in and they're patched. They're going to be nicotine free as they go through those early sort of dangerous moments of detoxification, but they're not necessarily appropriate for the Quitline yet, right? They're not necessarily making a quit attempt. They're being tobacco free, nicotine free, really tobacco free, if you patch them by virtue of the hospital's policy, but not because they're actually making a quit attempt, right? So they're not, maybe that's what I mean by clinical priorities. And of course, staff constraints are always a thing where here what I primarily mean is, maybe you for whatever reason have elected to do a single hub of care. So you have one tobacco treatment specialist. They're only doing tobacco stuff on Fridays. And so maybe you don't do Quitline referrals any other day of the week, or you save them until Fridays or whatever, something like that. Okay. So that covers our organizational criteria for referral. So once we know who in our catchment area is going to get that recommendation, then we can start to do some math, right? And this is what I'm talking about. So the numbers you're about to see on this slide are from a survey of clients in court-ordered substance abuse treatment that we conducted a few years ago. So to start, we're going to say that from start to finish, the entire screening to referral process should take between 3 and 5 minutes for the intervention part and 2 minutes to actually fax in the referral. And that's actually a really big overestimate, probably. So in this example, we're going to say that at this clinic, they see 600 unique clients per month, right? So the rule we're going to establish is that everyone gets screened at every visit, right? As long as it's been, let's say, 30 days between their last screening. Screening in between the 30 days is recommended, but we're not going to audit it, right? That's kind of what I mean, which means we'll be screening 600 clients every month. Now, screening takes almost no time. And in fact, it can be done on paper, right? During the intake session, that's the thing that the client fills out themselves when they come in for certain new services. So about 17% of the folks that we surveyed at a substance abuse facility were ex or never smokers. And so we offer them a brief bit of encouragement and just move on. But we do have to assess the stages of change of the remaining 83%, and that's about 500 clients. It's actually 498, but for ease of carrying the number in your head, let's just say 500. Remember that our base assessment is readiness to quit. It may not be ideal, right? But I've already mentioned this. You could just have that on the form as well. And what we found is that about 65% of people were in the preparation and action phases. So they're the ones who would meet our inclusion criteria to get a referral. And I know that the slide says 54%. That's what I was kind of stumbling around. That 54% is 54% of all 600 clients, right? So it works out to be about 65% of the 83% who are current smokers, okay? And that's, so now we're down to about 324 clients who are gonna need all 3 to 5 minutes of our clinic time to discuss the quit line and propose the referral, and some percent of them will require another 2 minutes for faxing the referral back in and collecting and acting on the fax backs. Okay, so assuming you spend 3 minutes with each client and get no referrals out of it, that's going to be 27 hours in a month. And if you spend 5 minutes with each and everyone accepts the referral, that's going to be 38 hours, right? So that's our range, 27 to 38 hours, and that averages out to be about 33 hours per month. That's about an hour per day, and which then we would recommend dividing up between all staff that are available in the 12 to 16 hours that your clinic is most likely open. Now, I don't know if that number sounds like a lot to you or a little bit to you. And frankly, it's just ballparking some basic figures and then applying them as is to a completely different environment. So, your mileage may vary. There are, of course, adaptations. You might be able to make your script much faster than 3 minutes. You can probably make alterations to your faxing process so it's less than 2 minutes, et cetera. So you might be able to work closer to that 27-hour mark, or even lower than that. So yeah. So now that you have a rough idea of how much time you'll be spending and where that time will be spent, you can start developing your workflow. And a lot of people prefer the classic model with one individual, normally a PCP, performing all of the tobacco-related stuff. And that design certainly benefits from centralizing and from simplicity. You may like it as well for whatever reason, but the HWP normally does recommend scoping the 5 tasks down to the lowest level practitioner that can do that task. So ask, that screening is done on paper with the potential interaction of a medical assistant or whoever you have working the front desk. The actual referral can be done by a peer or a nurse navigator, depending on your system. But generally speaking, someone who is used to engaging with clients in a joint decision-making process related to their treatment plan options. And the advice to quit and other medical Q&A may be handled by a doctor or a nurse practitioner or something like that. Your specific workflow is just going to vary based off the number of staff you have and their education, licensures, their knowledge, their skills, their passion, all those things. The point here is that from a planning perspective, you can start naming names and getting people trained up, right? Every program has a design, and the design is chosen by combining your organization's goals with your client's needs, and then that's all mediated by capacity. You'll also want a way to measure whether you're hitting all those goals, and you'll want a process to measure your successes versus your plans. Obviously, project management is an entire course by itself, but my short course begins with making sure you're measuring what you're doing. You're not measuring a proxy for what you're doing. You're not measuring a hope for what your project may do. If your program is intended to make quitline referrals, then your measure is how many quitline referrals you've made and nothing else. So that is going to be arrow 4 here, right? So on this chart, you see there are 4 things that we can count in our basic quitline setup, and that's how many people are coming through the system. And then you ideally be screening 100% of those, but you may not hit 100% for any number of reasons, right? So then the next thing is how many screen positive. You don't have any control over that. And then actually how many quitline referrals are you actually offering to people? So 1 and 3, you might be able to predict how many of what those numbers will be, but you don't have any control over it per se. Arrows 2 and 4, you do. Those are the things that you can change, you can get better at as time goes on. And then I would go ahead and add, because I've already mentioned it, that how many people accept a referral from you, actually answer the phone when the quitline calls, and how many people actually enroll is something you may be able to impact down the line. Once you have the script really nailed down, you can start to think about the quality of that script to see if there are ways that you can intervene with the client to increase their motivation after the original talk. That kind of leads us here, where initially you really are just thinking about these really early stages. How many are you just screening everybody? Then later, once you've got that really down, you've got that down to a process, or down to a science, you can then think about making sure that we're offering the education and the referral. And then you can tweak that. Are we appropriately tailoring that education? Are we being as enthusiastic as we can be? Are we really adhering to all of the best practice strategies for being persuasive? And then as you as you get more practice at the early stuff, then you can sort of make those improvements in the phase 3, phase 4 stuff that may or may not have an impact on your Quitline enrollment, right? And it could be the case that you really just, no matter what you do, you just can't impact enrollment. And so maybe if you were looking for ways to improve, maybe what you do is you keep increasing, I should say, the level of readiness for so instead of saying like, well, we start off referring anybody who was a 5 or above. Then maybe bump it up to 6, right? You bump it up to 7. You're looking to we're trying to maximize our efficiency by maximizing our effectiveness, right? And so there are things that we can tweak, right? And that's the whole point of having a sort of blended approach where you don't necessarily have to make every improvement right away. Think about your project in phases. So due to when we're thinking about tweaking, I should say, when we're thinking about tweaking, go ahead and we always recommend doing the PDSA process, the plan, do, study, act, and that gives us to act and then adjust and relaunch. That's what we're really talking about there, right? So you do the thing, you measure the stuff, and then you study what you measure, and then you act again. Now, due to time limitations on this presentation, I can't present a lot on like specific tailoring options, but I do highly recommend downloading the 2 reports pictured on this slide. The first was researched and authored in part by me, looking at specific issues associated with low-income callers to Quitlines. The other was researched and authored in part by my co-presenter today, Derek. Being low income is a key cross-cutting issue. And while rurality has potential cross-cutting effects, its main contribution to our talk today is on hard to reach communities. Rural communities are hard to reach by virtue of the fact that they are literally geographically far away. But many of our populations of concern are metaphorically hard to reach by virtue of marginalization and distrust, that kind of stuff. Interestingly, quite a few of the strategies that apply to reaching geographically distant communities is actually pretty similar to the strategies that we use to reach those populations that have been distanced as a result of public policy. But that is going to end my talk today. Thank you all so much for your attention.